I'm delighted to introduce Jayne Robbie. Jayne is a senior lecturer in diabetes care and specialist podiatrist at Birmingham City University and University Hospitals Birmingham NHS Trust. And she's going to be talking to us about the use of compression for patients with diabetic foot ulceration. So over to you, Jayne. Thanks ever so much.
So thank you very much for inviting me. As Sarah introduced, my name's Jayne Robbie. I'm a podiatrist by background. I also lead the vascular MSc at Birmingham City University, so I kind of wear a bit of a dual hat. So I'm part-time academic and part-time clinical podiatrist working in a diabetes MDT. So what I'm going to try and do today is give you an idea about the use of compression within the sort of diabetes foot sphere from my perspective as a podiatrist. So I'm taking off my kind of vascular hat there, and I'm going to kind of try and challenge some of those historic practices. And as Joe said at the beginning, that's that say it, share it, change it idea. So what I want to kind of do is debunk a few myths around diabetes and diabetes foot disease. And give you a bit of confidence about linking with your wider MDT, your interdisciplinary team and network around you. And I realise that some of you might not work in a team environment, but there will be people working in your area that you can kind of build links with and network with. So within the diabetes foot ulcer arena, the goal of any compression for us, as the previous presenters have said, is to improve circulation by providing some external pressure. And that can be the application of bandages, it can be the use of specialised stockings, it can be the use of some inflatable devices. And I'm not going to talk about those individual kind of compression devices themselves. I'm going to talk about compression kind of as a whole. So why is compression in diabetes a cause for concern? Well, as Annie said, you know, this idea around peripheral arterial disease, and we get very fearful with people with diabetes because they can, you know, not all people with diabetes, but quite a lot of people with diabetes can develop complications. And those complications can mean that they don't feel things like they used to, like they should or they used to. So they develop some peripheral sensory neuropathy. So their sensation to their limbs, particularly their feet, isn't as reliable as it could be. Or they can develop some problems with the circulation, with the flow to the foot. And bearing in mind that the feet are the furthest point, one from the spinal cord and two from the heart, where the circulation comes from. If you're getting any problems in either of those two areas, you're going to get problems in the periphery, in the toes particularly. Compression is standard in venous leg ulcers. It's not necessarily standard in diabetes foot ulcers because their etiology is kind of different. And as a result of that, any use of compression in people with diabetes needs careful consideration. And as Annie said, about a really careful and really robust clinical history to enable that you to be confident that if you're going to apply any compression, that it's not going to cause any additional harm to the person. But studies have shown improved healing rates for people with mixed ulceration, so ulceration that has you know, a sort of diabetes venous underlying etiology, with that use of mild to moderate compression. And I'm going to talk about these two guidelines, the International Working Group for the Diabetic Foot and the National Institute for Health and Care Excellence, NICE, guidance about compression therapy. But both of those guidelines have said that compression therapy can be used in people with diabetes if they have coexisting venous insufficiency, but after vascular assessment has confirmed adequate perfusion, because we don't want to be compressing a limb that has a reduced arterial blood supply, because we're going to reduce the blood supply to the peripheral tissues and we're going to increase any risk of hypoxia and tissue necrosis, and that's obviously a harmful situation, and it's not something that we want for our patients. So if we look at those two guidelines in order, the International Working Group guidelines, these were updated in 2023, and they state that in people with diabetes and a foot ulcer, we should consider compression therapy if there is associated venous disease and there is no significant peripheral arterial disease. That sounds fairly clear, but for me, that idea around what is significant, because what I might think is significant as a podiatrist, somebody else might not think is significant, or what you might think is significant, I might think as a podiatrist. No, that's fine. So we need to just clarify this term of significant. So we need a vascular assessment that should be mandatory before we apply any compression. And we should also be being mindful for those people out there who are self-managing, those people who maybe have diabetes, but aren't considered to be high risk. So they might not fall into, vascular or podiatry services, but they might then be self-caring. So they might be buying things off the internet, or they might be buying things from Amazon, or my friend down the road is wearing this and they've said that it works really well, so I'm going to give it a go. So we need to be mindful about some of the advice and information that we give people with diabetes about the use of compression. And this idea around the use of an ABI, an ankle brachial pressure index. So we compare the pressures between the blood vessels in the ankle and the blood pressures in the arm. We want that number to be, as near to 1. We want those pressures to be as similar as they can be between the two areas. A toe pressure, and Annie mentioned about that. We use toe pressures routinely in podiatry, not for compression, but as an indicator of peripheral perfusion. So that perfusion into those very small vessels in the toes and in the sort of distal feet, as a mechanism of maybe giving us a bit of confidence about healing. So it might inform some of our dressing choices, or whether we're going to do some debridement or surgical procedures, and it would give us an idea around healing, not necessarily for compression. And then this TCPO2, that's transcutaneous oxygen perfusion, and that's a sort of clinical device that we often use in hospitals. So if you work in community, you probably won't be familiar with that, but I wouldn't worry too much about those things. It's particularly around palpation of pulses. Can you feel the pulses in the feet? Is the skin warm? Is it pink? Is the patient complaining of pain? Have they got pain at rest? How far can they walk without any pain? If they have a wound, does it heal up fairly quickly? So those ideas around your vascular assessment, and then supplement it with, if you have a handheld Doppler, can you hear the blood vessel? What does the sound of the way of the pulse, what does it sound like? Are you getting some idea about the compression and relaxation? So are you getting a slightly sort of different beat, or are you just getting a whooshing sound as the blood just rushes through a calcified vessel? If you have a sophisticated Doppler and you can see some of the waveforms, can you interpret what the waveforms mean? So we're looking at pulses, we're looking at perfusion, we're looking at waveforms, and we're listening to the quality of the pulse. And then if you can do an ABPI, then obviously do that and record your findings. And we would use that ABPI to inform us about the sort of status of the arterial health. And it says here from this IWGDF guideline, reduced compression if mild arterial disease is present, and they've given us a value, and they've said mild arterial disease is 0.5 to 0.8 milligrams of mercury. So if you're having a result around the 0.8 or sort of 1 value for your ABPI, then you would be hopefully safe. If the rest of your vascular assessment was appropriate, you'd be safe to apply reduced compression. And then so this is supported by NICE, and again NG19, which was updated in 2019, also says for people with diabetes and a foot ulcer and signs of venous insufficiency, you might consider referring to a multidisciplinary team for vascular assessment, so to see a specialist like Annie, who you heard earlier, before initiating compression. And that will mean that you have a full vascular workup, you have the ABI, and you have this decision around the use of compression in that limb. NICE also goes on to state no compression unless arterial perfusion is adequate. So a bit like the statement before where it said significant, we have this term adequate, and what does adequate mean? And that we should integrate compression into wound management only after a specialist evaluation. So again, this comes down to using your MDT. In association, we have the Society for Vascular Surgery in the UK and the American Podiatric Medical Association, who've also come up with guidelines. These are a little bit dated now, but again, guidelines around the use of compression in the diabetic foot. And they talk about associated edema, so swelling in the limb, venous insufficiency, and they state that compression may be beneficial after careful vascular evaluation. So you can see through all of these guidelines, this is the fundamental thing, isn't it? It's a careful vascular evaluation. Compression type or strength should be customised dependent upon arterial status. So again, we're looking at, in diabetes, we're looking at arterial blood flow, not just the venous blood flow. And they state that for an ABI, so again, that pressure index, but above 0.8, we can use full or maybe some of the stronger compression devices. If we're between 0.5 and 0.8, we should use reduced compression with caution. So again, we want to have those people under surveillance. We want to give them information and advice. We want to be checking them regularly and making sure that we are not just checking the foot and the limb for the compression, but we're also checking the blood flow and the sustainability of the blood flow within that limb over time. Because obviously in people with diabetes, diabetes is a long-term condition, and whilst they may have had an ABI done 6 months ago or a year ago, things can significantly change within that time frame. So we need to be doing regular re-evaluation just to make sure that we are cautious about continuing with compression. And they state this guidance here states that if you have an ABI of below 0.5, that we wouldn't use compression at all in that person. So for people with diabetes, just to round up, we would use compression in people with foot ulceration and diabetes if they had coexisting venous insufficiency. If we can rule out significant peripheral arterial disease, or if that peripheral arterial disease is mild, so if their blood flow is adequate, like was stated in the previous on the previous slide. So we might use compression in those mixed etiology ulcers, so people who have a diabetes ulcer, but they also have some venous disease or some peripheral edema. We might use compression to help with their venous return. For people who have edema, and if it is significant lower limb edema, we might want to do that if they had a venous or lymphatic origin to that edema, and they had ulceration in their feet. And we might do it after arterial assessment to make sure that they have a good blood supply. So what are the precautions? So for me, the precautions are anyone with peripheral arterial disease. So if they're complaining of rest pain in their legs when they're walking, if they have skin or tissue changes, if they have distal necrosis, if they have absent foot pulses, if their feet are cold, if their feet are significantly cyanotic, that might make me think that actually, without even doing an ABI, I might, as a podiatrist, be thinking I might not be wanting to do significant compression with that person. And the reason for that is that we don't want to make any ischemia or tissue necrosis worse. So here we've got the indications for your ABI, for your ankle brachial pressure index, 0.8 to 1 to 1.3. Compression is generally deemed to be safe. 0.5 to 0.8, we might use modified or light compression with caution, so with regular surveillance. Anything below 0.5, contraindicated. Toe pressures, transcutaneous oxygen pressures may also be used if you have the ability to do that or the kit that can do it. But if not, your ABI is considered to be a reasonable standard to give you confidence about using compression. But just again, to be mindful, if we're going above 1.3 of a pressure index, an ABI is unreliable due to arterial calcification. So if the arteries are really hard, we can't compress them. If we can't compress them, we can't get a pressure index that's reliable. So again, I would be cautious if an ABI reading was giving me something that was above 1.3. I might be thinking, actually, I might not want to use compression in that individual. That basically just repeats what what we've already said. We want to monitor frequently, and we want to do regular wound inspection and reassessment of perfusion. And that's the key for me. We're not just putting this compression on and going, thanks very much, goodbye, we'll see you in 3 months or 6 months or whatever. We want to be doing regular inspection, and we want to be doing regular reassessment. Now, that might not be that we do, at every visit we do an ABI. That probably wouldn't be sustainable or feasible, but we would do a vascular assessment. So again, we're going to evaluate pulses. We might use our handheld Doppler. We would definitely do an investigation of the peripheral tissue. We would want a subjective report from the patient about pain and about any discomfort that they might be having with the compression. And we might want to look at the wound. Is the wound looking like it's improving, or is the wound looking like it's deteriorating? And if any of that changes, we might want to reevaluate our sort of treatment plan at that point. So I've already mentioned that your ABI can be falsely elevated in calcified arteries, and you might want to look at then another sort of modality to assess that circulation if you were desperate to put on compression. However, you might be fairly confident at that point to say, we're not going to progress. Mild compression or modified or reduced compression can be achieved with multi-layer bandages, reduced tension wraps or compression stockings. I would just say about compression stockings, I see a lot of people who come into my clinic in the hospital with compression stockings on, and a lot of my patients will find them very difficult to get on and off, often because of their manual dexterity, often because sometimes they get hand complications as a result of neuropathy, so they might lose a bit of sensation in their fingers, so their manual dexterity starts to run out. They might have some sarcopenia, some muscle loss, so their grip strength is reduced, so pulling on long socks or stockings might be difficult, and they may have some visual impairment that means that they can't see to put them on or pull them on appropriately. So again, in people with diabetes, we might want to modify or monitor that. And we'd want to combine in people with foot ulceration compression with appropriate offloading of the wound, so taking the pressure off with some other device, be that some footwear or some modified insoles or something of that kind of sort of device. We want to make sure that our wound care and our wound treatment is optimized, and we want to think about glycemic control. In people with diabetes, if they run regularly high blood sugars, that will impair their wound healing. So again, we need to have that sort of holistic approach where we're not just looking at compression in isolation. We're looking at the wound, we're looking at the pressure into and through the wound during walking or standing, and we're looking at their overall sort of metabolic status with regards to their diabetes control. And the table there is just a summary of those 4 guidelines that I showed you before, that you might find helpful just to have in summary state. So how do we choose the correct compression in people with diabetes? for the majority of us, elastic or inelastic multi-layer high compression bandages are the treatment of choice. But in younger people, or those who are self-caring, or those who have that manual dexterity and ability, compression hosiery might be a more useful option. So they can take it on and off, they can bath or shower, particularly if they're young and active. So we can use, you know, the whole range of compression devices accordingly, but only, you know, as I say, if our vascular assessment, our arterial assessment is appropriate. So just a little bit about edema. We see quite a few people with foot ulcers in diabetes who have edema, and that will obviously affect our ability to feel the pulses. If they have a lot of fluid in their tissues, we can't necessarily compress the vessel with our hands. So we might not be able to palpate a pulse, but that's where our handheld Doppler is useful, because then we can maybe hear the pulse. We can hear the quality of the pulse into the foot. And the management of foot ulcers in people who have edema can be challenging because of the amount of exudate. Obviously, if you have a lot of fluid in a limb and you have a hole in that limb because of you have an ulceration, there's going to be a lot of fluid leaking out of that wound. So again, we have issues around maceration. We have issues around smell. We might have issues around regularity of dressing change that again might all come into play if people have edema. And interestingly for me, some research that I found when I was preparing this presentation was lower limb edema in people with diabetes has been linked in several studies to an increased risk of amputation. So for people who, you know, we might think, oh, it's only a bit of edema, but actually for some people, if they have diabetes, that can, you know, increase their risk of needing surgical intervention and amputation. So we shouldn't be, you know, we should be viewing these, you know, these issues with seriousness. So wound healing, you know, we see these edematous limbs to various degrees, and wound healing is often prolonged in the presence of edema because it reduces capillary blood flow. If the tissues are full of fluid, those little capillaries can't fill up with blood quite as well, because they get quite a lot of external pressure from that fluid in the interstitial tissue. Fluid accumulation in the limbs increases wound exudate. I mentioned that just now, and it also raises the increased risk of infection. If wounds are very wet, if the tissue is very macerated and fragile, if wounds are sitting in wet dressings, that acts as a reservoir for infection, and infection can cause a further tissue breakdown and further tissue damage that then can result in people needing to be admitted into hospital for intravenous antibiotics, can need surgical intervention, can ultimately need amputation if that infection if we're unable to bring that infection under control. And also, interestingly, that fluid increases the limb weight. So that increased fluid reduces people's mobility. They don't walk like they did. The pressures through their feet aren't like they were. They can't get footwear on appropriately. If you look at that foot there, you know, that foot's not going to be able to get into an off the peg shoe that they might be able to go and buy in a shoe shop. You know, this is going to become more of an issue in terms of footwear. So they're going to need some footwear from external providers. So that might be a sort of specialist footwear service. It might be through your orthotics department, your local hospital. The fluid can cause joint pain because people aren't walking appropriately, and the pressures through their legs and their feet are a little bit unbalanced. They can get soft tissue pain, so they can get some discomfort, and often around when they're, you know, if they're sitting or standing, they might say that they're getting more aching in their limbs, that sense of their limbs feeling heavy. And again, we need to differentiate that from neuropathy and from neuropathic pain. And it can increase their plantar pressures and cause more tissue stress, which means that their ulcer may stay open for longer. And also these limbs, the heaviness in these limbs can increase a person's risk of tripping and falling. If they're not wearing shoes that fit properly, they may trip more often as they can walk out of their shoes, or their shoes fall off their feet because the swelling varies through the day. They may get swelling that overlies the shoe, so they might get these sort of feet that where their shoe is on, but they have all this tissue that kind of oozes over the top, and then we run the risk of further tissue damage. So there's a lot of challenge around edema in feet, and the use of some compression, or some compressive device to help to manage that edema is quite appropriate. Compression therapy can be used for people with edema and diabetes. Once we've excluded arterial disease, I'm going to keep saying that because it's a really important point. Also, once we've assessed the peripheral neurological supply, so can they feel things? Do they know if it's too tight? Do they know if it's painful? Do they know if they're getting more problem? And we need to think about this thing around tissue stress and tissue shear, and if they're developing some callus or callus buildup around ulcers, that macerated callus that sometimes you see around an ulcer, or they're developing some physiological callus as a result of how they're walking, that callus needs to be managed, and they might need a referral to podiatry for that. Thinking about lymphedema and that more lymphatic cause of edema in the limb, that's the it leads to microangiopathy, so we get small vessel disease, those very small arterioles and capillaries in the foot, increased permeability of the capillaries, and increased lymphatic load. We can have a problem as well if we have some lymphatic problem with inflammation following infection. You can get sometimes lymphatic failure around insulin injection sites, so we might see that if people inject into their thighs, and that might also be something that we need to consider. People with diabetes, particularly those people with type 2 diabetes, they may have an increased risk of cardiac failure, and that cardiac failure can cause peripheral edema and fluid retention in the limbs. So again, thinking about the whole patient and their sort of whole the whole problem. We need to identify those people with coexisting lymphedema or chronic edema and diabetes because of their risk of prolonged wound healing, increased risk of infection, increased risk of amputation. And we need to initiate any treatment strategies at an early stage, because what we want to do is to prevent long-term complications and deterioration. So we need to continue to do our ongoing vascular assessment. We need to measure all of those or benchmark all of those serial vascular assessments against their baseline. So what were their measurements like at the beginning? So how big was the wound? How deep was the wound? What was their ABI? What was their pulse quality? What was the pulse sound? What was their pain? We need to be able to compare sequentially the findings at each of our clinical visits. And we're monitoring the skin for infection, for increased duration of ulceration, for any peripheral vascular changes, or any deterioration in their neurological supply. So I talked about offloading, and on offloading we can do that sort of the compression offloading of the venous supply, but also that clinical offloading of the pressures within the foot to enable a foot wound to heal. We need to think about how active a person is. So, are they able to undergo any physical exercise? Can they walk around? Can they, do any pottering around in the house? Anything that they can do to increase that calf muscle pump will reduce the stasis of blood into the foot, or the stasis of fluid into the foot, particularly if people are sitting for any period of time. We generally tell people to sit with their foot elevated. We tend to tell them to, every 20 minutes, pulse their foot up and down like they were operating a pedal on a car, or do some little cycling movements with their ankles, just to increase that calf muscle pump activity to improve their blood flow. If we are thinking about particularly people with type 2 diabetes and peripheral edema, we might want to have a conversation around weight management, and making sure that we can try and optimize people's body weight, because again, if people are carrying significant amounts of body weight, that can increase their sort of venous load and can increase their risk of edema. And working with our wider medical team for diuretics if they are indicated in that person. So thinking about, whether a low dose diuretic or some sort of integrated diuretic management to help people to remove some of that fluid that's building up in the tissues. So this is something that I quite often see in my hospital, on my hospital ward. We do our ward rounds, and we quite often see these dressings that have been put on, bandages that have been put on with or without compression, that have moved away from the wound. They've moved around the limb. They're no longer providing the therapeutic management that we want them to provide. And we need to be stopping this. This is a harm. Joanne mentioned this at the beginning about harm, and this is something that we need to be monitoring regularly. We need to provide appropriate offloading. If that dressing, that bandaging modality isn't doing that, we need to be doing something different. We need to be looking at our wound care. We need to be doing appropriate glycemic control, being mindful that patients move around. Those dressings may not stay where they were put, and being mindful that edema can go up and down. So sometimes if people have been at rest, the edema can reduce, and then once their legs are dependent or they're standing, that edema can increase. That's just a decision algorithm that I'll let you have a look at off the slides. I've talked about the other risk factors, and to be aware of those as you're going through, and to be aware, for people, we want to make sure that the person is comfortable and confident as well with using this, because for quite a lot of them, they are self-treating. That's just my summary of what I've talked about, and again, you can have a look at that at your leisure. And those are my references. So thank you very much for your time. I hope that's challenged some historic practice, and it's given you a little bit of confidence about the use of compression in people with diabetes and diabetes foot ulcers.
Thanks, Jane. Someone's just put up about looking at that decision algorithm again. I don't know whether it's a document that you could share.
I can. I think I've shared the slides with Legs Matter, so the slides are available. It was a slide that I created myself, so
okay. I mean, if that algorithm, it can be made available as a standalone, we can send it out with the certificates and things. So
yes, absolutely.
Just liaise with Dawn about that.
I'll send it to Dawn. Yes.
There's been some comment around neuropathy. So obviously foot neuropathy, yes, and as a contraindication to compression. There's a comment from someone saying that they've had patients with neuropathy who are they're very self-aware, and they monitor their own skin and things like that, so it's been safe. But obviously there are going to be some patients who wouldn't have the ability to do that but haven't got that sensation. Does it mean we can't, or is it just with caution?
I think exactly that. I think it's with caution. I think you have to, on an individual basis, if you're happy their arterial supply is good, you've done your appropriate documentation, you've documented your the neurological deficit, and you've documented the advice that you've given the person, and you're fairly confident that they are capable and competent, and they're safe for you to do that, then absolutely on an individual basis, I would say then that's absolutely fine. But I would probably want to have them under fairly close surveillance, so they know who to contact if they've got a problem. They know what a problem is. So, we tell them, we're very specific, because I know in my practice, one of the things I've changed in my practice is that I've stopped saying to people, if you have a problem, give me a ring, because that's not telling them what a problem is. What do we want them to ring about? So are we saying if there's more exudate? Are we saying if there's more discomfort? Are we saying if there's more fluid? What are we saying is a problem? and they know who to contact and they know when to contact, then absolutely, you know, I think on a case by case basis, you could probably give it a try and see how they cope with it. My concern with people with diabetes, with neuropathy, is not so much the mild to moderate compression, it's if we're doing stronger compression, is that if we do start compressing tissue and they are unable to feel that compression, you know, how sort of how confident would I be that, you know, that they're not going to come to any additional harm?
I think you've just raised the importance again, or about the language that we
Yeah,
use. You know,
yeah,
you interestingly, you know, bringing up around that word significant and adequate. It's a bit of a cop out in guidelines, isn't it?
it is.
And I
It
think it
is.
is about sort of, you know, interpretation, and it needs to be really clear within local policies, you
Yes.
know, around what actually is meant by that. Because otherwise
Yeah,
people goes, well, what's significant? What's adequate?
exactly. And,
Yeah,
and I think when you're documenting things, you know, you document the numbers, and so then you can, you know, you can, you know, you can then refer back and you can say, well, the number was this, or the you know, this is my definition of, you know, because as those words are very subjective to me. It's like saying to somebody, it's like I just said now, you know, it's like saying to somebody, oh, just call me when there's a problem. You know,
yes.
that's like my plumber saying, well, call me if there's a problem. Well, what's the problem? Do I have water gushing out of my, you know, gushing out of my front door, or do I need a drip out of my tap? You know,
Yeah.
it's that, isn't it? And we will always have people who are worried well, who contact
Uh-huh.
us immediately when there's just the slightest little niggle of something, and we go, no, that's fine, you're absolutely fine. And we have the person who you know, like the Monty Python Knights, has got a leg that's hanging off, and they're going, oh no, I can still go to work, I'm fine. You know, it's again, people are, you know, people will always interpret it how they want to interpret it, and as long as we are confident in our own assessment and documentation, then and we're backed up with the guidelines, then I think, you know, we've done as much of a duty of care as we can.
Absolutely. Finally, one more question from Andrew. Do you have any comments on the initial findings of the diabetes peripheral arterial disease study by Imperial College? I'm not sure what he's referring to. I don't know myself, but
No,
just a
no,
question in the
that
Q&A.
that sounds very broad. I'd have to say, in terms of compression, no, I don't.
Okay, thank you. That was brilliant presentation. I think, you know, my message really from this is really get to know your podiatrists as well, because sometimes, you know, my experience from across the UK, it's a bit disconnected. Some podiatrists will compress, others won't. There seems to be a bit of toing and froing between the different services. So I think it goes back to what I think a lot of our speakers have said around the importance of networking, getting to know your peers, having conversations to make sure that what we're doing for patients is safe, but also consistent as well. So thanks for that. That's really brilliant. Thanks, Jayne.